Welcome to the training Right Care, Right Time, Enhancing Crisis Response and Collaboration in Mississippi. My name is Jennifer Hodson, and I am with Health Management Associates, or HMA. HMA is a leading independent national research and consulting firm that focuses on improving the administration and delivery of public health, healthcare, and social services programs. HMA is supporting the Mississippi Department of Mental Health in its efforts to enhance the state's crisis response system by providing online crisis response trainings and monthly crisis provider convenings. We're glad you're with us today. The training will cover 3 learning objectives. First, by the conclusion of the first objective, participants should be able to describe the key components and structure of Mississippi's behavioral health crisis response system. Second, participants should be able to define best practices for triage and prioritization during behavioral health crises and identify effective methods for cross-system coordination to support individuals in crisis. And lastly, the third objective will support participants in developing approaches for ensuring follow-up care and making timely, appropriate referrals. Let's dive into the first objective and cover the key components and structure of Mississippi's behavioral health crisis response system. According to Mississippi's Suicide Prevention and 988 Guide for Schools, suicide prevention is a collection of efforts to reduce factors that increase the risk of suicide and promote resilience. It requires a combination of efforts that work together to address different aspects of the problem. Keeping people safe and supported is something found all along Mississippi's crisis care continuum. Mississippi's behavioral health crisis response system is centered around providing community-based, person-centered, and recovery-oriented care. It is a system of care grounded in the expertise of its communities all across the state, with a focus on the belief that individuals can overcome behavioral health challenges with appropriate support. As we transition into the heart of the material, please pause this training and take a few moments to list out what you believe are the key components of Mississippi's crisis response system. Please note that while we all may identify different parts of the crisis response system as critical to delivering the best care, sometimes we are unaware of all the components that comprise Mississippi's robust and developing crisis response system. So feel free to pause the training while you think about your list and respond to this prompt. Mississippi's crisis care continuum covers each component from someone to talk to, someone to respond, somewhere to go, and someone to follow up. Each is vital to ensuring individuals get immediate and ongoing care to help prevent or reduce the severity of future crises. We will go through each component in greater detail in the following slides. One of the first crisis response steps is someone to talk to. The 988 Suicide and Crisis Lifeline is available 24/7 and is staffed with trained responders who listen to each caller with compassion and are trained to effectively triage and prioritize the level of response needed. I'm going to link on the slide the Suicide Prevention and 988 Guide for Mississippi Schools as one possible resource for you to review. Now let's learn a little more on the following slide about the history of 988 and its evolution as a resource in our state. Launched nationally on July 16, 2022, the 988 Suicide and Crisis Lifeline shifted from the 1-800-273-TALK number to the 988 short code. It responds 24/7 to calls, chats, or texts from anyone who needs support for suicidal mental health and/or substance use crisis and connects those in need with trained crisis counselors. It is free and confidential. Enhancements like geo-routing since September 2023 now direct 988 calls to the nearest crisis center based on location, improving locality and service responsiveness. The second step in Mississippi's crisis continuum of care is someone to respond. The services extended here include crisis intervention and mobile crisis response teams. Let's first start by understanding what crisis intervention teams do. Their purpose: CITs involve partnerships between law enforcement, mental health professionals, community mental health centers, and other relevant agencies. Law enforcement officers receive specialized training in recognizing and responding to mental health crises, de-escalation techniques, and connecting individuals with appropriate resources. CIT officers receive 40 hours of training on topics such as mental health diagnoses, medications, substance use issues, and more. They also receive hands-on instruction in de-escalation techniques and hear firsthand accounts from individuals who have experienced mental health crises themselves. The training they receive has a specific focus on safety for both the officers and the individuals in crisis. For more information, including how to arrange CIT training, contact Linda Foley at the Mississippi Department of Mental Health at linda.foley@dmh.ms.gov. Now let's talk about mobile crisis response teams, or MCIRTs. The purpose is to provide immediate on-site intervention for individuals experiencing a mental health or substance use crisis. Each community mental health center operates a mobile crisis response team. Teams are available in all 82 counties and can be accessed by calling the toll-free numbers listed on the chart to the left of the slide or 988. Services include de-escalation, risk assessment, crisis intervention, and connection to ongoing care. It is available 24/7 in all regions of the state. The third step in Mississippi's crisis continuum of care is somewhere to go. This includes diversion centers, peer respite, crisis stabilization units, and acute psychiatric hospitals. We will go through each on the following slides so you can deepen your understanding of each system of support and the critical role that it plays. Also on this slide are the regions and the areas where we have crisis stabilization units. We also have a map depicting where our acute psychiatric hospitals are located. Let's talk about diversion centers. The purpose is to reduce unnecessary institutionalization and support individuals in returning to their homes or communities. They're used to divert people from jail or psychiatric hospitalization by providing short-term voluntary stabilization. Short-term community-based alternative to inpatient psychiatric hospitalization or jail for individuals in crisis, and structured stabilization in a non-hospital least restrictive setting. Individuals typically stay 24 to 72 hours. Individuals in crisis who do not pose a danger to self or others or meet commitment criteria and just need structured support are ideal for this setting. Services may include temporary housing, peer support, case management and care coordination, and medication management. Staffing often includes peer support specialists and licensed clinicians. Mississippi currently has 2 possible diversion centers coming in 2026 in Harrison and Lamar counties. Let's talk about peer respite. The purpose of peer respite is voluntary short-term support in a home-like setting staffed by trained, certified peer support specialists. These individuals help prevent Escalation of crises offer emotional support and link their guests with outpatient services. Their approach is recovery oriented, trauma informed, and non clinical. Individuals usually stay 1 to 7 days. Peer respite is a recognized model by the Mississippi Department of Mental Health, but actual facilities are limited or emerging depending on local funding and community mental health center capabilities. Now let's talk about crisis stabilization units. The purpose of crisis stabilization units are to provide voluntary or involuntary inpatient treatment for individuals who need intensive services but do not meet criteria for hospitalization. They offer the ability to stabilize and discharge with a follow-up plan to community-based care. Typically, length of stay is 3 to 5 days. They are operated by community mental health centers and staffed with licensed clinicians, nurses, and peer support specialists. On this slide is a map of where our crisis stabilization units are located in Mississippi. Now let's talk about acute psychiatric hospitals. These are facilities that include Mississippi State Hospital in Whitfield, East Mississippi State Hospital in Meridian, North Mississippi State Hospital in Tupelo, South Mississippi State Hospital in Purvis, and Specialized Treatment Facility in Gulfport is a psychiatric residential treatment facility under the supervision of Mississippi State Hospital. The services provided include inpatient psychiatric evaluation, medication stabilization, treatment planning, and discharge coordination. Admission pathways include civil commitment process, emergency admission under crisis conditions, and step up from crisis stabilization units. They oftentimes are limited in beds and generally reserved for those who cannot be stabilized in the community. On this slide, we provided a map of where those acute psychiatric hospitals are located in our state. Now that we have gone through each system aligned with somewhere to go, let's cover the distinctions between each. So for peer respite, the purpose is to prevent escalation, the level of care is low, the setting is community or non-clinical, and the population served are voluntary and in early stages of distress. For diversion centers, the purpose is to avoid jail or hospitals. The level of care is moderate, the setting is community-based and staffed, and the population served are in crisis but not imminent risk. Our crisis stabilization units, or CSUs, the purpose is to stabilize crisis. It is for a moderate or high level of care. The setting is clinical, short-term inpatient, and the population served are high distress, possibly involuntary. And for our acute hospitals, it offers intensive treatment at the highest level of care in a psychiatric hospital, and it's ideally for those who are a danger to self or others or who may be experiencing things such as psychosis. The last step along Mississippi's crisis continuum of care is someone to follow up. Some would argue that this is the most critical stage to help support the individual toward improved health and well-being and preventing future crises. It includes services such as the involvement of community mental health centers and peer support. Let's first talk about community mental health centers. Their role is to serve as regional hubs for behavioral health services, including crisis intervention. Services include outpatient therapy, psychiatric evaluations, case management, substance use disorder treatment, intensive outreach services, law enforcement partnerships and co-responder teams. Each of Mississippi's 14 community mental health centers runs an MCERT, making 24/7 on-site crisis intervention available statewide. Community mental health centers also manage the crisis stabilization units and track outcomes and ensure accountability. Currently, there are 11 community mental health centers serving 11 community mental health center regions covering all counties in Mississippi. Now let's go through peer support. The role of peer support specialists is important. These are individuals with lived experience who have sustained recovery from a mental or substance use disorder or both. Many community mental health centers employ peer support specialists in outpatient settings to support people in recovery, help navigate services, and serve as recovery role models. Managed by the Mississippi Department of Mental Health, credentialing is done through a standardized training and certification process. Certified peer support specialists must complete ongoing education to maintain their certification. While non-clinical peer support staff typically work under the supervision of a clinical provider or program director, supervision is vitally important. So let's see how you did. Now that we are nearing the end of our first objective, how closely did your list of key components regarding Mississippi's crisis response system align with those that we just discussed? Are there some that you did not realize were a part of Mississippi's crisis continuum of care? Feel free to pause here in the training and think through your responses as compared to the ones offered under this objective. Feel free to rejoin us when ready. The second objective for this training will cover best practices for triage and prioritization during behavioral health crises and cross-system coordination. Before we get into the content for this section, let's run through a case scenario created for this training to think through how you will triage this individual in crisis. We will return to this case scenario later in the training, but feel free to pause this slide to think through your responses to each question noted at the bottom of the slide. We'll read through it together. So the name of the individual is James. James is 43 years old. He lives in rural Mississippi County with limited local behavioral health services available. James's background is that he's been diagnosed with schizophrenia and diabetes. He has a history of substance use disorder, although in remission. He recently lost his Medicaid coverage. He lives alone, has limited family support, and no personal vehicle. James called 988 expressing suicidal thoughts, auditory hallucinations, commanding self-harm, and feelings of isolation. His last contact with the healthcare system was 6 months ago. The call comes from a rural county with no nearby crisis stabilization unit or hospital with psychiatric beds. So here are the questions we'd like for you to consider. 1. How would you triage this individual? 2. Who would you coordinate his crisis care with? And 3. What additional considerations would be part of your thought process in providing James with person-centered care? Feel free to rejoin the training when you're ready. Welcome back. Reviewing best practices for triage and prioritization in crisis response for behavioral health includes several of the following. 1, that there's no wrong door access. There are multiple entry points to getting care. Real-time triage, so that you're interacting with an individual who is trained to help get you to the next service that you need. That there's a tiered crisis continuum so we can best deliver the right amount of crisis support to the individual where they most need it. It's the least restrictive, most effective setting we know that is successful in reaching people in crisis, where we offer assessment and risk stratification, and best practices include individual-centered, trauma-informed approaches. An important part of the triage and prioritization process is assessment and risk stratification. The assessments used help us to collect the information needed to determine the level of risk and the response needed to promote safety and access to the highest quality of care needed. This process includes identification of high-risk indicators such as suicidality, homicidality, psychosis, and use of screening protocols and assessment tools that help us to determine severity and next steps. Another part of the process is determining level of urgency. Is the individual in immediate danger versus non-urgent but needs a lot of support? And last is to differentiate between behavioral health crises from medical emergencies, such as a diabetes crisis, as well as having mental health symptoms or substance use intoxication. Some of the common evidence-based assessment and screening tools that you'll find in crisis care include the Columbia Suicide Severity Rating Scale, which you can receive training online. It's an hour of training. It's excellent and it helps you to know how to prioritize and triage an individual in crisis who is talking about wanting to harm themselves or end their lives. There's the level of care utilization system. Locus is for adults. Colocus is for children and adolescents. So that helps us to determine the right level of care. The American Society of Addiction Medicine criteria for determining substance use, and crisis assessment tool. Each of these assessments is linked on the slide for your review and to develop familiarity, as it may be useful to you in the field or may be used in the field and referenced. Regardless of the protocols and assessments used, it's always important to maintain an individual-centered and trauma-informed approach as a crisis care responder. This means following the best practice strategies of validate, don't pathologize, ask, don't assume, work to avoid re-traumatization by engaging the individual in creating a safe environment, respecting emotional boundaries, using trauma-informed language, such as validating, promoting choice and control, and using words that they use to describe their experiences versus clinical words or your own. We really work to avoid re-traumatization by avoiding blaming language and also honoring their personal boundaries. And ultimately, it's about focusing on the individual rather than their diagnosis. Another best practice is extending culturally responsive triage practices with language access and disability accommodations in the triage process. We want to use documentation and handoff strategies for clear and consistent communication of triage findings so we can have that seamless connection between the different crisis response teams and care being provided. We will obtain funding and insurance information if and when possible, and then implement that cross-systems coordination so that we can minimize the burden on the individual in crisis and their family and really promote that seamless crossover from one service to another. When engaging in cross-system collaboration, there are several best practices to keep in mind. So let's review them on this and the following slide. There are shared crisis response protocols. So many times we might create memorandums of understanding or MOUs among behavioral health, law enforcement, EMS services, schools, and hospitals so that we can ensure we're aligning a person-centered response. We can offer role clarity across systems. So who leads? Who decides? Does MCERT conduct the assessment? Does law enforcement then ensure, or before that, ensure scene safety when required? So it's very good when we're responding together that we know who starts, who does what during that, and who's responsible. The multidisciplinary crisis response teams deploy teams with clinicians, peers, and when needed, law enforcement to co-respond. They use de-escalation and trauma-informed approaches, and they've also received this kind of training, so they're familiar with what each of them is going to be able to provide. There's centralized crisis hubs or dispatches. So having that unified hub, like a 988 integrated system, fields calls and helps manage bed availability, dispatch teams, coordinating handoffs. So we really are working together as a seamless system of care, and that unified hub model has been found through best practice to make that a little bit easier. Some more best practices for cross-system coordination include sharing data and health information exchange. This enables real-time, consent-based sharing of crisis and care plans among emergency departments, mobile crisis teams, and outpatient providers using these interoperable systems. So we're not having those barriers of electronic health records that don't talk to each other, that we're able to patch through so that we can have that seamless narrative about the individual in crisis. Then there are warm handoffs. So these ensure direct personal transition between services. So when mobile crisis is bringing somebody to a crisis stabilization unit, that they're able to have a person-to-person conversation or handoff, and that reduces confusion or lack of information transfer. And this can be with peers or clinical facilitation. And then there's integration with long-term supports. And this is where we link crisis care directly to housing, employment, outpatient peer supports and recovery programs, ensuring that that follow-up component is seamless. Individuals in crisis are triggered by many different factors, and some of them could be related to basic needs, living environments, access to medications, food, in addition to support and quality mental health care. So those long-term support connections and plans are vital to preventing future crises. And they really do require strong cross-system coordination. Now let's go back to the case scenario that we began with in this section of the training. James, the person we were introduced to earlier, called 988 expressing suicidal thoughts, auditory hallucinations, commanding self-harm, and feelings of isolation. How does what you considered for triaging and prioritizing his care compare to some of these ideas on this slide? So for triaging care, assessing immediate safety, prioritize response level, consider transportation and access barriers. For coordinating your MCERT, 911, and hospital care for a person with psychosis, communicate role clarity, hospital decision-making capabilities, and cross-system referral and follow-up. And then some additional and important considerations are cultural and community factors, comorbid medical needs, with diabetes and other factors that could also be contributing to exacerbating some mental health symptoms as well as physical symptoms, and then funding and insurance navigation. Our last objective for this training will be used to cover approaches for ensuring follow-up care and making timely, appropriate referrals. This again is a critical part of the triage and prioritization process in a crisis response system. So why follow-up matters? One, it reduces risk of relapse, hospitalization, or suicide. Mississippi's mobile crisis response teams ensure clients are scheduled with a provider and monitored until the appointment, which in 2024 helped divert 23,420 people from more restrictive settings. It boosts treatment engagement and outcomes. Evidence from emergency department linked follow-up programs shows that active referrals and phone outreach significantly improve connection to care compared to passive methods, like giving people a list of resources. Several important points of follow-up are part of a best practice crisis response. So your mobile crisis response teams, they initiate contact, they schedule next step care, and they will remain connected until follow-up is complete. Your community mental health centers ensure that the client has a scheduled appointment, ideally within 7 days, and same day, if possible, of the crisis event. Your certified peer support specialists or your peer bridgers are certified peers who accompany discharged clients, especially from inpatient or crisis units, and help them get to those follow-up appointments and stay engaged. The 988 crisis call centers are crisis counselors who provide that compassionate, immediate care and referrals and connect follow-up outreach, calls, or texts to ensure transition to local care. And then the interagency follow-up protocols, those are your structured agreements, your memorandums of understanding that help define those responsibilities across the systems, like your mobile crisis teams, your emergency departments, your peer programs, and they guarantee client tracking and referral completion. So really trying to narrow the distance and the gaps between each system of care to create the best possible partnerships and outcomes for the individuals served. When referring individuals for follow-up care, it is important that this is done quickly and appropriately. There are several methods to help promote a successful experience. We have talked about warm handoffs on a prior slide. So I want to go over that one more time because it's so important. And remember, these are warm handoffs that involve direct transfer from one provider to another with that person-to-person contact and ensuring that seamless care and clear communication. So sometimes there can be delays in written documentation or even confusion in what's written. When you have that person-to-person contact, oftentimes questions can be asked, details can then be added, and clarity can be achieved. Another key component to making appropriate and timely referrals are using evidence-based triage tools. There's several listed on this slide, such as the CSSRS, Locus Colocus, ASAM Criteria Guide, and these all help us to identify appropriate placement. So is the individual best served in an outpatient setting, a crisis stabilization unit, an inpatient setting? This way we're ensuring referrals are clinically matched. Another is active scheduling and follow-up. So mobile crisis teams, when involved, they can schedule the next appointment on site even or via phone at discharge rather than relying on the client's self-scheduling. So giving somebody a list of resources when they're in crisis and have limited capacity greatly reduces the likelihood that they will follow up. Or if they do call the first number on that list and they don't get a person who answers the phone or they don't get a call back, oftentimes they'll interpret that as not being important and it'll just sort of reinforce that crisis that they were in. So we really want to try to have that person-to-person direct scheduling to reduce any misinterpretation by the individual in crisis or gaps in connection. And your community mental health centers will ensure that the client has a scheduled appointment, ideally within 7 days. And again, as we said earlier, the same day if even possible. And then that peer support involvement that you've heard throughout. Peers can accompany and coach clients to their first post-crisis appointment, reducing drop-off and increasing engagement. So we have seen peers play vital roles throughout all parts of the care continuum. And oftentimes they come with the credibility of the person in crisis, seeing somebody who's gone through something that can understand how hard it is to navigate from breath to breath, from word to word, and from resource to resource. It is also best practice to approach follow-up care using a person-centered response approach. This is where you recognize and address person-centered factors influencing crisis experiences and preferences regarding follow-up engagement. So everybody's different, and tapping into that, there's just a few questions that we can use that will carry you a long way. So when we incorporate these person-centered relevant questions into our safety planning process and our intervention to conversations, we really enhance those referral connections. So Galante has come up what we call the 4 C's. And the first C is call. So it's just asking the individual in crisis, what do you call your problem? What do you have? What name do you have for it? Sometimes words for individuals carry a lot of stigma, a lot of pain, a lot of experiences of rejection and distance from people. So they might come up with other names for something that they believe promotes safety. So I like to ask people, when you're referring to what you're experiencing, what do you call that? The next is cause. What do you think caused your problem? This is a really important question because we can get at if it was a loss of job, a loss of resources, loss of relationship, things they may have read or heard. So, really important that we're understanding what may have caused it because that can then impact next steps that we take, the care plan, and the follow up. Cope, the third C, how do you cope with your condition? This gets its strengths. And while somebody is in crisis, the goal isn't to cheer them up. The goal is to understand what they need. But having an idea of how they cope, what strengths that they have access to, can help us to build a thoughtful plan that's embedded in their communities, their histories, their backgrounds, their connections. So cope can be very important for somebody, such as somebody who's connected to their spirituality. And that can be a source. And that can be a conversation that helps them then feel connected and then move to the next step in the care process. And then the last is concerns. What concerns do you have about the condition, what you're experiencing, or what we're recommending today? So a lot of times we'll experience people agreeing to a care plan, but then not following through. And that often is when the care plan was decided for them, not with them. So by asking what concerns they have about the plan or steps moving forward, we can prevent a potential lack of care by then just taking a few steps back and reconfiguring the plan so that it's something that really fits the individual. We also want to adapt our communication and follow-up approaches to honor our clients' individuality and the backgrounds and traditions that are important to them. We also want to be curious about, again, strengths and barriers that the individuals could have that enhance or inhibit their follow-up care, such as age, location, beliefs, family, rules, and values. During the process of follow-up, there are several barriers that may be present in the crisis response experience. This slide identifies several common barriers, evidence-based solutions aligned with each one, and examples from Mississippi on how they are working to reduce access to care barriers. So we'll go through these, but encourage you to go ahead and pause if you'd like to look at them more. One barrier is transportation. A solution is to have mobile teams offer transportation or ride coordination. Mississippi has an example with the Pine Belt mobile crisis teams. They have helped clients access appointments, providing transportation when needed. Another barrier is communication drop-off. An evidence-based solution is to use phone or text calls or active outreach reminders. An example of this in Mississippi is the emergency department linked follow-up programs. They do rely on active counselor-led follow-up, so reaching back to those individuals who have received care in the emergency department to see how they're doing, if they were able to connect with those follow-up resources. Another barrier is rural isolation. An evidence-based solution is peer support and telehealth, reducing those geographic barriers. So if people can't get face-to-face with a resource, having peer support and telehealth can help patch between services needed and services on location. In Mississippi examples, there are 14 mobile crisis units that provide in-person services within 1 to 2 hours statewide. Another barrier is no-shows or engagement. Our peer support specialists and peer bridgers engage clients in appointment readiness and trust building. And in Mississippi, our certified peer support specialists and peer bridger programs facilitate first visit attendance. So really walking with somebody in crisis and not just pointing them in the direction they need to go. And that helps to reduce no-shows and improve engagement. Another barrier, interagency gaps. We have spoken a couple of times already today about the importance of those signed memorandums of understanding between crisis response system members and how you can share those functional tool assessments to make sure that all of our services and our level of care are lining up. The Pine Belt Co-Responder Program in Mississippi uses the daily living assessments, and it really helps them to facilitate a shared referral system. And then another barrier is language. Language service or alignment with agency that offers services in the language needed for optimal care. So even though we have people who may speak a second language, when they're in crisis, oftentimes people prefer to speak in their dominant language. There are just words that come with the language that they're most familiar with that are deeply emotionally connected to their experience. So we want to try to facilitate services and supports in their dominant language as much as possible. And Mississippi's Department of Health regularly trains community interpreters and maintains a language access department and language access plan, which is linked to this slide. Let's practice again with another case scenario developed for this training. Maria is 28 years old. She lives in a small Mississippi town. She's African American and has a history of depression and anxiety. She recently lost her job, no stable housing at the moment. The crisis event was Maria was brought in by Mobile Crisis Response after a neighbor called 988 due to concerns about suicidal ideation and withdrawal from social supports. Maria was evaluated, stabilized, but declined inpatient hospitalization. She did accept community-based follow-up. The mobile crisis team provided a brief safety plan. Maria reports that she does not have reliable transportation. She prefers follow-up care that respects her cultural background and involves peer support. She expresses some distrust of healthcare providers due to past experiences. Your task is to think through the following 4 questions. 1, what types of follow-up care should Maria receive? 2, how would you ensure timely and culturally responsive referrals? 3, what strategies could reduce the risk of Maria disengaging from care? And 4, who in the system, the mobile crisis response teams, the community mental health center, peers, others, should take responsibility for Maria's follow-up? So feel free to pause and think through your responses to these questions. Welcome back. Now let's debrief the case scenario and apply what we have learned through this training about effective follow-up. So effective follow-up would include scheduling a follow-up appointment as soon as possible, ideally within 7 days, that's coordinated by the Community Mental Health Center, who's managing the mobile crisis response services accessible to Maria. We would want that warm handoff to peer support specialists. Remember, Maria had even asked for peer support involvement, who share cultural backgrounds that are similar to Maria and have the lived experience to build that trust and engagement with her. We want to work toward address those transportation and any housing barriers through case management and community resources. We want to incorporate Maria's cultural preferences into safety planning and service referrals, including offering culturally responsive providers or supports. Want to regularly monitor and outreach if Maria misses appointments through proactive re-engagement efforts, and this can be done through those peer support specialists. The use of shared referral and tracking systems to ensure accountability and communication among crisis teams, community mental health centers, and peer programs, and providing education to Maria and her support network about the importance of follow up and crisis resources like 988 and even peer respite centers that might be a resource that could benefit Maria in the future. In this training, we've also provided for you a list of linked references for future review. So we encourage you to revisit this slide, save these references for future use. Thank you for completing this module with us today. A training library is being developed through June 2026, compiling recorded and accessible resources to support you in your role. Frequently check the Department of Mental Health's website linked on this slide for updates and new training uploads. Here is a list of some of the training topics and other trainings that are being recorded that will be housed on the Department of Mental Health website, referenced and linked on the previous slide. Please make sure to follow us on social media platforms such as Facebook, YouTube, and Instagram. Thank you for your participation and have a wonderful day.